thank you very much. Thank you to my colleagues for happy opportunity to read a lecture at this honorable symposium. It's first time that I make it, and that's why I'm a bit nervous. Okay, let's start. Unlike the situation the professor just mentioned, we perform a lot of MRI examination in our city. Our city is 1.5 million people live in the city, and we have in our region 30 magnetic resonance imaging, and we have one imager per 150,000 people. That's why we know something about MRI, and I try to show you how we use it in our everyday routine. Our clinics are very large clinics. I walk into the most big clinics in the region, and I'll show you some examples. I'll show you our approaches, how do we use this powerful instrument. I might say two powerful instruments. First instrument is MRI imager, and the second one is the contrast. And as we say in Russian, we shouldn't hammer the nail with microscope, and sometimes the contrast is used instead of the hammer. We just infuse it slowly and then slowly scan after infusion, and our important information that we might get out of the examination is lost. And I'll show you how we use multi-parametric MRI to get maximum out of our examination. We have two heroes on stage. The one hero is iodine, and the second one is gadolinium. I do believe that not many of us saw them in their pure form, and you can enjoy them how they look without any chemical substance. What are uses of contrast medium? First of all, it's the detection of the spots of blood-barrier barrier disruption when the contrast just accumulates in such spots, and it tells us nothing about what disease caused it, and just the blood-brain barrier disruption. The second use of contrast media is the depiction of the vessels. We can depict both veins and arteries, and also we can depict small microvasculature using perfusion techniques, and we use this technique very often, especially in CNS application. Perfusion can be analyzed just looking at the maps quantitatively or qualitatively. We prefer to evaluate them qualitatively because it's very rapid, and in most cases it's enough. Of course, in some cases we compute the maps, CPV, CDF maps, and so on, and in some cases it also helps us to solve some questions. Filling the cavities, it's not very frequent application of the contrast, but sometimes we should use it, and in most cases we fill the cavities with iodine-containing contrast media, but off-label use is also possible for gadolinium-containing contrast. For example, gadolinium-enhanced direct infusion MRI myelography, as several authors tell us, is more susceptible, is more and even more specific than CT myelography in some cases of cerebral spinal fluid leaks, spinal, both and cerebral, but we routinely do not perform it. Several scenarios where we use the contrast. It's first of all, it's neuro-oncology. Most contrast-enhanced examination are performed in neuro-oncology. It's of course vascular diseases, both in acute situation and in chronic situations when we just perform secondary stroke prevention. It's also the diseases from the list that we see here. I wouldn't just read it before you. Where we need the contrast media, when we need it in neuro-oncology. First of all, it's detecting. In most cases, detection doesn't need the contrast media. We see the tumor in cell, but sometimes we do not know is it tumor or something else, and in differential diagnosis is more easy using contrast enhancement, and staging and grading also is impossible without contrast infusion. And in staging grades, although the current guidelines, they do not tell us that we should use perfusion routinely, but we prefer to use it because differentiation from radionecrosis and tumor regrowth is much more easier using perfusion imaging. And criteria Raynaud and metastasis Raynaud, they also do not tell us to use routinely perfusion, but we also substitute sometimes the original native and contrast-enhanced regular magnetic resonance imaging with perfusion imaging. Prognosis is also can be evaluated using perfusion because the more hyperperfused tumor has a less favorable prognosis. I also told you about recurrence detection and dissemination, especially in children tumors. Spinal dissemination is impossible to detect without contrast media. And this is a very interesting case where the contrast infusion helped us to correctly localize the tumor in brain, and you see that we lack the image of the normal epiphysis, normal pineal gland, and pineal gland is this large. So this tumor is from the pineal gland, it's just displaced posteriorly, and from the first glance it appeared to be a tumor of the cerebellum, but from the careful look it appeared that it was a pineocytoma, and it was proven afterwards after removal of the tumor. In vascular diseases, first of all, we need to evaluate the lumen, the stenosis, occlusion, and so on, or the lack of stenosis or occlusion. We also can check the microcirculation in acute setting, and experimental studies allow us to check this in chronic setting. Collateral vasculature is also very important, especially in setting of acute thrombolysis, and especially and percutaneous thromb extraction, which we perform in our both hospitals where I work, and we also noticed that good collaterals bear more good prognosis for the patient, and so that's why the next line is percutaneous treatment. Vessel wall characterization can be achieved both using contrast and without using it, and we do not routinely perform it because many articles they state that it's just also experimental methods, and we do not know how to implement it in our daily routine. But we all know that the vulnerable and unvulnerable plaques can be easily detected using high resolution MRI and also with using of contrast media. And of course, the differential diagnosis, sometimes the disease they look like a stroke, but actually they are not stroke. Inflammation, demyelination. Of course, the activity is the mainstay of the treatment of the patient. Activity can only be assessed just using contrast enhancement. Differential diagnosis is also very important because tumor-affected myelination sometimes resembles tumors, for example, lymphoma, and we can easily differentiate, especially with perfusion imaging, this tumor-affected myelination from the tumor. Several examples how we use contrast in infection and demyelination, and here we see that the capsule of the epidural abscess very nicely depicted, and the intracerebral abscess also very nicely depicted, the wall, and we can operate it easily. T2-weighted images, they do not allow us to easily detect fluid collections, and after we infuse the contrast, we can easily see non-enhancing areas that collecting with pus and contrast-enhanced walls, margins of the abscess. Here is also very interesting example. Here we see the ring-enhancing lesion, mass lesion with perifocal edema, and from the first look we decided it was metastasis, but perfusion allows us to discriminate it, and we finally got to a decision that it was a toxoplasmosis solitary lesion. And the interest in this case is the patient denied that he had an HIV infection. After that we checked, and she was positive for HIV infection. So we made a diagnosis using MRI perfusion. And the last example is the intradural abscess in the child with spinal dystrophism. On the T2-weighted images, the wall of abscess wasn't nicely depicted. Several other examples of spinal infection, it's the spondylodiscitis and epidural and paravertebral abscesses, and T2-weighted images. Again, they do not allow us to nicely see the pus collection, which is very nicely seen after contrast enhancement. We can differentiate cellulitis, myositis from the liquid pus collection. Neurodegeneration, it's mostly the research field, and sometimes in multiple sclerosis, for example, the symptoms and signs in the patient, they are due to neurodegeneration with lack of activity. And of course, we see no activity, but patient deteriorates. We can conclude that it's due to neurodegeneration instead of active inflammation. And anti-inflammatory drugs are do not need in such cases. Neurotrauma, we rarely use contrast enhancement, especially in MRI neurotrauma, but it's more often used in CT when we suspect the vascular damage, for example, dissection or thrombosis of great arteries and veins and so on. And the main indication for direct infusion of contrast in cavities, it's CSF leaks, post-traumatic or spontaneous, as I already told. How can we use contrast? The most ancient way of infusing it, as I already told, is just slow intravenous infusion, sometimes in many cases manual infusion, and then different modes of scanning can be applied. It's delayed scanning after a certain delay, 5 or 10 minutes. It's more modern imaging, multi-phase scanning, 2 or 3 phase, and the more phases, the more it approaches the perfusion scanning. And CT and MRI angio also can be used with contrast infusion. And the more often and more often we use the high-resolution 3D scanning to facilitate neuronavigation, to obtain the most successful biopsy specimens, and so on, to be able to multiplanary reconstruction. Just detection of blood-brain barrier leaks is sufficient when we know the disease. For example, in this case, we have a lung cancer and metastases with typical looks. This is very rare localization, but this is known breast cancer and metastases in the optic chiasm. And this is very rare case. It's meningeal enhancement. It was impossible to tell what caused this enhancement, but later it appeared to be primary diffuse melanosis of the meninges. All these 3 examples are just blood-brain barrier disruptions, and nothing can be said about the nature of the lesions that caused it. Delayed scan is very useful technique, although current recommendation for imaging of multiple sclerosis, they do not tell us to perform routinely delayed scanning. Anyway, we can see that the images with later images are better depicting the active lesions. The same is said about pituitary microadenoma. Only on the first 3 phases we can see it on the normal pituitary tissue. Perfusion scanning is also a very valuable technique. Of course, you all know that the perfusion directly correlates the tuable tissue in acute settings of the stroke. Here we was able to differentiate between glioblastoma multiforme, hyperperfused, and lymphoma that is hypoperfused, although they look the same. Here's an atypical meningioma that had very high perfusion digits, and here the radionecrosis that appeared hypoperfused on perfusion scanning. And here the tumor that is grown again but lacks contrast enhancement, although it has hyperperfusion in the tissue. And this again, this is toxoplasmosis, it has no hyperperfusion. Angio, of course, as already told, cannot be used in CT without contrast, although at MRI we can use it without contrast, but sometimes the results are not satisfactory. We overestimate stenosis, for example. High-speed malformation that should be scanned only with high time resolution, as in DCA, and by now we have no such machine at MRI and CT that allow that to image high-flow malformation. So, can contrast media be obviated? We saw that it, in most cases, obviates, in about 80%, but in most cases we cannot do our correct diagnosis without using contrast media, especially at CT. On MRI, sometimes we can obviate them, but in most cases no, because I already told before that many questions we should answer, they are required to infusion of contrast media. Filling cavities, of course, we cannot fill cavities with nothing else but with contrast medium, just like dentists do. We fill the cavities with our iodine or gadolinium containing contrast media. How many contrast media should we use? It's principle. ALARA is the same principle as an X-ray. It's sufficient to have a single dose, use single dose. If you think that a lower dose can be sufficient, for example, microadenoma pituitary, use lower dose. Sometimes we should use bigger dose. Administration. 2 ways. It's simple slow flow infusion, and we prefer power injectors because it can allow us to standardize infusion. Filling the cavities, here example, on contrast MRI, MILO doesn't allow us to detect the fistula, and direct infusion allowed us to do so and successfully to treat the patient with spontaneous intracranial hypertension. And how to decide to use contrast media? When we see that from the native images we cannot obtain the correct diagnosis, it depends on clinical scenario. If diagnosis is no, we should check for activity and so on. And sometimes we are too lazy to use contrast. This shouldn't prevent us from using, so we shouldn't rely on other people to perform this contrast examination needs in this particular patient. This is the example we missed the correct diagnosis. We decided that it was stroke because patient refused contrast, and after 3 months the stroke has grown and we see it wasn't a stroke, and it accumulates contrast, and if we perform this from the first time we definitely might establish the correct diagnosis. Future trends. Maybe sometimes we will have the methods that allows us to establish everything without using a contrast. Sometimes we use them with available options, but again, if we need activity, if we need tumor growth, and if we need lumen of the vessels evaluation, we cannot activate contrasts. Organ tissue specific contrasts. For example, if we will have the glia or neurocytes specific contrast, of course it will help us a lot. And I should say that all images in this presentation were obtained using Gadoist because I think it's the most versatile preparation on the market. It allows us to use it from the 0H. It has very high relaxivity and very high signal at both middle and high Tesla machines. And take-home points, I'm finished. In most clinical scenarios, to obtain every information we need to treat a patient, the use of contrast is obligatory. Disease can be missed without contrast infusion. Tumor can be taken for a stroke, as I showed, and so on. How can we decide to use contrast? We should obtain available guidelines to be familiar with them. And in the most clinical scenarios, it's indicated should we use them or not. Of course, it depends on particular clinic, and sometimes even on the availability of the contrast on the shelf. And sometimes we also do not have them, but I think it will be absent such cases in the future. So the modes of need to be comprehensive, the multi-parameter examination is more informative than just slow infusion and slow scanning. Power injection, I prefer this. Angioimaging, of course, should be done with contrast, and Gadoist already told about it, and non-contrast imaging, and to try to obtain all the information we need. By now is still experimental. We cannot not to use contrast in most patients. And you see that the bigger contrast, the easier detection of the disease. Thank you very much.
Thank you very much, Andrei. Maybe some questions from the audience. We have a little time. Yes, I see one question, please.
My question is on the acceptance of your results by clinical staff. I mean, for how much degree do the neurosurgeons, neurologists, infectionists, and so on really need and really claim your results with contrast enhancement? I mean, what's the force the contrast enhancement is driven by?
Who decides to infuse the contrast to the patient?
Yes, and in more precisely terms, do the neurosurgeons insist to inject the contrast or not?
You know, in our hospitals, neurosurgeons, they trust us because we work together for long, and they know that we know for sure when to use it and when not to. But when the neurosurgeon from outside, sometimes yes, he insists, even if the brain scan is completely normal and he doesn't think it's meningeal process, he still insists. And some neurologists, when they suspect demyelination, they also insist on contrast enhancement despite the fact that images are completely normal. Yes, such situation they exist, but in our clinics where I work, we decide it by ourselves in most cases.
Thank you.
So they are interested in result.
Yes, please.
My question is, what is the difference in speed of power injection contrast media with different concentration?
Yes, it's a very good question. thank you for the question. We perform both examinations with high contrast and middle contrast concentration contrast media with speed of 4 milliliters per second. And I noticed that curve at the perfusion scanning goes below 0. If you try to use the same dose in the high contrast contrast media, high concentration contrast media. That's why we split the dose in two. And to obtain perfusion images, we use the 1/3 of the dose. And then, after perfusion images are obtained, we infuse the 2/3, remaining 2/3, and then obtain high resolution delayed scanning.
Thank you so much, Andrei. Thank you, Dr. Zoryev. I suppose if you have any other question, we will discuss it after the end of our session. Thank you so much.
Thank you very much indeed.